So today we are here with Doctor Nicola Gaibazzi, who is the head of non-invasive cardiology of the University Hospital of Parma in Italy. Hi Nicola.
Hi Sergio, thank you for having me here.
So today we're going to talk about stress echo. So we're going to start about contrast agents. So which is your opinion about contrast agents, why we should use them during a stress echo?
Sure, well, they're probably underused, contrast helps a lot in echocardiography in general, not only during stress echo. And contrast helps you see better when you have suboptimal images. And so when I say see better, I mean that, for example, the use of very low mechanical index imaging helps a lot in that it puts together perfusion and wall motion, and so it may highlight defects that you may not see without contrast. The first example I prepared for you is as easy as it is. This is a two-chamber view, obviously, but you can see that probably you're not seeing sufficiently well the anterior distal segments, while just the use of contrast at rest highlights a perfusion defect and obviously a wall motion defect. These segments are akinetic probably, and so you could detect an LAD severe disease in a patient with, you know, those types of chest pain when your high sensitivity troponin is borderline, you have no delta, and the chest pain is not clear enough. So it helps a lot. Another case I prepared for you, Sergio, is a case of ST elevation MI, which was reperfused very rapidly, just 30 minutes. But you can still find, using this incredible tracer, microbubbles are incredible tracer of the microcirculation. So the artery is open here, but you have persisting microvasculature defects. So that's quite important. It's a pure tracer of the microvasculature, and so it helps a lot during echo.
Okay, thank you. So talking about stress echo, one of the parameters is CFR, so it's coronary flow reserve on the LAD. So how to detect it, and which is its clinical importance?
Yes, coronary flow reserve is an important adjunct to the stress echo parameters that you can assess during stress echo, in particular during vasodilator or stress echo. It is more sensitive as far as diagnostic yield, and it's something that helps you investigate the microcirculation and not only the epicardial. So it's kind of addition of both the epicardial district and the microvasculature. So it looks like also an underperformed measure. I don't know exactly why. It appears to be kind of geographical assessment. So maybe in Europe we use it quite a lot. It's not used in US. But anyway, the key to the measurement of CFR is that it can be measured without contrast. So if you're a skilled professional, you can do this, and quite easily actually. But if you're not so proficient in this method, you can help yourself with contrast. So contrast makes it very easy. So this is just a couple of slides I mounted a few years ago maybe, showing how what's the technique to measure the coronary flow reserve. So the velocities, it's based on measuring the velocities at rest and then after the stressor, whatever stressor you use. So the LAD is quite difficult to spot without contrast. You need to be skilled in that, but you need to know the anatomy basically. So you have shadows from the ribs, and you have to know that you can find a distal LAD and a mid-distal LAD here, so there's the rib in between. So it's not very easy. It's a basically modified two-chamber. Yes, again, you can see that. But when you use contrast, this is going to be much, much easier. This is the pulse wave Doppler, very good tracing, TVI. And when you use contrast, just 0.5 milliliter of sonography, for example, or whatever else other contrast media, you can see that it gets highlighted by the microbubbles, so the LED becomes much bigger and you can locate it very, very easily.
So the normal values are more positive than 2, isn't it?
Yes, we use this very easy cutoff, which is 2.0. I think there is only one exception to this cutoff, which is in athletes. Well, basically athletes have a very high coronary flow reserve, and 2.0 is not fit for all. So I would say that in patients, in standard patients, 2.0 is okay. I would use maybe 2.5 in young athletes, because it happened that we saw patients with coronary artery disease in the LAD, and still they were athletes, obviously, 2.1 of CFR, because they started very high, 3.5 and so on.
Okay, another parameter is myocardial perfusion. So we all know that there are many methods to detect perfusion, for example, CMR, aspect, and so on. So why we should detect perfusion with stress echo, and how to do that?
Well, perfusion using stress echo, using echo, basically, using ultrasound, has the advantage that echo has when compared to all other methods such as CMR or PET, which is so easy. It's bedside, it's portable, and very friendly to every clinician. So this is the upside of perfusion using contrast echocardiography. But obviously, there are also some drawbacks. You have a little bit of noise, and so the signal to noise ratio is not good as you can find CMR or PET imaging. But if you get proficient enough to assess contrast perfusion, you can have valuable information from this technique. And basically the principle that you use is that you inject contrast, and you can use a pump or you can use also bolus as we do. And when you're at a steady state, you use an impulse, a train of impulses that basically break the microbubbles, because the mechanical index of the ultrasound gets back to the normal standard high MI. So you have, see this please, this is before these impulses are given to the patients, and this is the impulse, the train of impulses, and after the impulse, you can see that the myocardium where you have a concentration which is way lower than the cavity gets completely cleared from the microbubbles, and you can you can assess. You can see that this is the ECG, the QRS, this is one cycle after the other, and you can see how it replenishes. This is the term you use. So there should be an homogeneous getting back of microbubbles here, or signal. In this case, where you have circumflex and left main, you can see that there's some subendocardial defect here, starting in the mid-distal LAD and territory, and then going back here in forechamber to the lateral. So you have both coronaries involved, and the normal replenishment would be that you find something like that after the impulses are delivered. And so it's a brilliant method to assess perfusion. It's not that different from cardiac magnetic resonance, for example. In magnetic resonance, you use the you use the phase when the contrast is injected, and here you deliver the impulse and you see how it works after that. But it requires good images. Mm-hmm. So this is just one of the advantages of using contrast. I always say, and probably said to you a few years ago, that contrast is very helpful for three things during echo and stress echo in particular. So you can assess, first of all, wall motion as it should be. So with perfect images where the endocardium is perfectly visible in the 17 segments. Then you have the CFR, which is a very important additional parameter to add on. And then perfusion, which is the most difficult to acquire, but it's satisfactory when you have good images. Do
you have any example of myocardial perfusion?
Sure, I have plenty of, but this is just one that probably helps you understand what you can do with microbubbles and perfusion. So this is the case of a stented lesion with the septal branch that was closed, and you can so easily spot this very tiny defect here. And there's another one, which is more clear probably, which is in the lateral circumflex artery. So this was a stented LAD where the septal branch was occluded by the operator, and we could very easily spot it. And it's there is actually, this is triggered imaging, so you use just a few images typically at end systole, but you can use real time, as we have shown in the prior images like this one, where you can assess at the same time wall motion and perfusion, and just few methods would give you this capability in real time.
Okay, Nicola, so as we understood, so you have a multiparametrical approach in stress echo, so you evaluate wall motion, perfusion, and CFR. So why we should use a multiparametrical approach, and which is its application in terms of specificity and sensibility?
Yes, obviously that sensitivity and specificity build up the accuracy of the test, but often this is a trade-off, clearly. The use of more than one parameter to assess the coronary circulation helps a lot in terms of sensitivity, but it will bring down specificity a bit. The trade-off is positive overall, and you have higher accuracy. So there are a bunch of studies that were able to demonstrate this. We did some also. The very concept of the coronary artery disease, stenosis, and the grade of stenosis is that when you have a very mild plaque, which is clearly not obstructive, you have a normal CFR, maybe more than 2, maybe 3, and normal perfusion and normal wall motion. As far as the coronary stenosis gets worse, you have that when you're around 50%, you can probably spot some perfusion defects, and the CFR is borderline or slightly reduced to 1.9 or something like that, where you can find also non-echocardial disease. You can find microvascular disease also there in that spot. When the coronary artery plaque goes far beyond this, you will have wall motion defects. So we build a concept which is based on more or less, the numbers may change and depends on the population that you are assessing, but when you use standard wall motion stress echo, so whatever the stressor you use, you have a sensitivity that is for sure not beyond 70%. I doubt it. Maybe it's more 50 or 60%. But you have also feasibility, which is not 100%, because you have poor acoustic windows, and that happens in clinical routine. So when you use contrast, this is the typical setting where you use contrast for wall motion, right? So we call it LVO, left ventricular opacification setting. You have just a slightly higher sensitivity, maybe 75-80%, but you have higher feasibility, almost close to 100%, because with contrast you can image almost any ventricle. So you can do this at rest and stress and be quite confident about wall motion assessment. When you use perfusion, your sensitivity goes sky high, and maybe even too much, because you lose a little bit in specificity, because you're getting trapped in your diagnosis, everything. So microcirculation, you can see perfusion defects and cardiomyopathies. So it's not very specific for a stenosis, for a severe stenosis, but it helps a lot in cardiology in general. So, yes, and this is CFR. We did a study, it's 10 years ago, and we could study 400 patients with my friend Dr. Rigo, and we could build more or less, this type of studies, you always have some referral bias, so this is the limitation, which probably is anyway scattered around the 3 modalities. So they probably cancel out when you compare the modalities. And so you have wall motion, which has a very high specificity. This is the blank one, the white thing here. And then you have the CFR, which brings your specificity a little bit lower, but a little bit higher the sensitivity. And just consider that you are assessing only one coronary artery, but the results are on the 3 coronary arteries. So it's so potent, CFR, that it's comparable to wall motion, which assesses the 3 territories, where we, with the CFR, only 1. When you add CFR on top of wall motion, you have this very good step up, which is significant, and you have specificity which is not perfect, but sensitivity is more than 80%. And if you use perfusion, you have the highest possible sensitivity. So this is the concept of the multiparametric stress echo, that you have more variables to assess. It requires a little bit of thinking around this. So you should not consider too much perfusion in a 90-year-old boy, but you may do this when you see an athlete and you want to be very, very sensitive in your diagnosis, for example, myocardial bridges and so on.
Okay, so my final question is about prognosis. So do you have any data about prognosis and the relationship between the different parameters and prognosis?
Yes, we were luckily able to start and collect the data regarding perfusion and prognosis in 2007. So we now have very long follow-up, and we are able to have at least 10-year follow-up. But I have to say that well earlier than me, Tom Porter in particular started collecting this data, and there are a couple of papers in the European Heart Journal and various circulation that he and his group published regarding the incredible power, capability of perfusion to stratify prognosis for heart events, I would say myocardial infarction and mortality basically. We also did together with Tom another circulation in 2012 where you can see quite easily a result which is apparently banal. It's the same with all the methods. The typical thing of stress echo is that you can have wall motion and perfusion at the same time. But if you see now CMR studies, the Kaplan-Meier curves appear the same. You have that normal patients, so normal for wall motion and perfusion, they have an incredible, nice follow-up with few events, so a very low event rate. Then perfusion defects, but normal wall motion, have a slightly worse outcome. And then when you have wall motion abnormalities, which are which require a very high plaque burden in your coronaries, you see that the events are much higher. So basically, when you study the accuracy in the prognostic setting, you see that perfusion and contrast in particular. So there is also demonstration that contrast helps when you just assess wall motion. So it's better than assessing wall motion without contrast. But if you're also able to assess perfusion, you will be capable to stratify much better your population. And this is in the acute setting from a group. This is in the what we now call chronic coronary syndrome setting. This is, together with Tom, in more than 3,000 patients, we try to analyze different settings for regarding the type of stress echo, the stressor, which is dobutamine and dipyridamole, and several significant subgroups: diabetes, age, women and men, so gender, and history of CAD, obese or non-obese patients, which is questionable. In fact, that in obese patients you could study perfusion, but in particular, Dr. Roxy Senior group studied this issue in particular. So in each and every subgroup, you're able to study this. And just to conclude, this is a study where we also assessed the CFR. This was together with Tom Morwick, and you have an almost perfect stratification when you also use CFR. So wall motion, CFR, and perfusion can produce this type of level of outcome, of prognostic outcome that helps a lot in treating coronary artery disease. Even more today, that we know that medical therapy is basic, is key to treat those patients. So the decision is not I send him to PCI or not. The decision is how intensively I should treat this patient. So maybe that if you find very mild disease, you can decide to be less intensive in your medical therapy, or you can grade your treatment.
Okay, thank you very much, Nicola.
Thank you, Sergeant. And again, thank you for having me here.